joining us today, you guys. We'll go ahead and get started. We still have a few people logging in, but they can just join us as we get going. We are really lucky today to have Dr. Yoon, who will be teaching for us today. He is one of our neurosurgeons here at St. Mark's Hospital, who has been here since August. And so we're going to turn the time over to him and let him introduce himself a little bit more, and we'll kind of go from there. So, let me just, here's the remote. Let me share your screen. Yes, thank you.
Hi, I'm Yoon. I'm one of the neurosurgeons here. I just want to introduce myself. I'm originally from California. So I did my undergraduate at UC San Diego, and I studied bioengineering. Then I went to medical school at Loma Linda University, also in Southern California. And then I moved here to Salt Lake City to do my residency at the University of Utah. And during that 7-year training program, I did an enfolded fellowship in endovascular surgery. And then after I finished residency, I did an extra year of cerebrovascular surgery, where I spent a year doing both endovascular and open vascular surgery. I don't have any financial disclosure. So I'm the newest member of a group called Neurosurgical Associates here in Salt Lake City. We work out of Intermountain Medical Center and also at St. Mark's Hospital. And my primary goal here at this hospital is to build the stroke program to the next step. So currently we're a primary plus stroke center, and so we provide medical and endovascular treatment of ischemic stroke. Basically, we're able to offer mechanical thrombectomy, pulling the clot out. The goal is to become a comprehensive stroke center sometime early this year. And that would include offering both open and endovascular treatment of hemorrhagic stroke. And so I just wanted to spend some time going over the difference of those. So some of the objectives of this hour, to define patient symptoms consistent with stroke, understand the difference between ischemic and hemorrhagic stroke, identify the causes of hemorrhagic stroke, identify treatment options of ischemic and hemorrhagic stroke, and consider process improvement opportunities to expedite patient care. So what is a stroke? It's kind of a broad term. It's basically any neurologic deficit attributed to an acute focal injury of the central nervous system by a vascular cause. So cerebral infarction is probably what we all think of when we say stroke, and this is an ischemic type of stroke, and the vast majority of strokes are ischemic. But then you also have intracerebral hemorrhage, which is a hemorrhagic type of stroke, and subarachnoid hemorrhage, which is another hemorrhagic type of stroke. So why does it matter? Well, stroke is the third leading cause of death in the United States, with approximately 140,000 stroke-related deaths each year. And every year, approximately 800,000 people will suffer a stroke. And on average, someone suffers a stroke every 40 seconds, and there's a stroke-related death every 4 minutes. And it costs the United States about $34 billion each year from healthcare services, medications, disability, and it's a leading cause of serious long-term disability. And this is just a graph kind of showing that the stroke numbers are going up as the population continues to age and our diets continue to worsen. So what is an ischemic versus a hemorrhagic stroke? So an ischemic stroke is basically not enough blood going to a territory of the brain. So, so right there, you've got a blood clot there, and this whole part of the brain is being deprived of oxygen and nutrients, and so this part of the brain becomes dysfunctional. Now, a hemorrhagic type of stroke is where bleeding occurs inside or around the brain tissue. When it occurs inside the brain tissue, it's called an intracerebral hemorrhage. And if it's around the brain tissue in the subarachnoid space, we call that a subarachnoid type of stroke. So when it comes to ischemic stroke, all the hospitals that you work with are basically clamoring to get you guys to us as quickly as possible. And we're trying to get the patients to the CT scanner and to the next step as quickly as possible. And the whole point is that in stroke, time is brain. And so if you think of every second, you lose about 32,000 neurons every second, you have an equivalent of 8.7 hours of accelerated aging. That's time you'll never get back. So per stroke, on average, you lose about 36 years, okay? Per hour, you lose about 3.6 years, okay? So every hour you can get that patient faster to the end point, you are saving them 3.6 years, you're saving them 120 million neurons, okay? So that's why it's a big deal. And, you know, a lot of patients will come to me and say, so what is it exactly that you're doing when you're doing a mechanical thrombectomy? And I basically tell them that I'm a glorified pipe or a plumber, okay? So if you think of a toilet that's being clogged, think of an artery that's clogged. Sometimes it's a soft clot that's easy to get out, and Drano will do the trick. You know, you just pour some Drano in, and the artery or the pipe will get open. Sometimes when you've got, you know, years and years and years of buildup, sometimes really bad plaque, you need to kind of bring out the big guns. So you need kind of like this rotor-rooter thing. Okay, and that's what we sometimes will have to do. So as far as the vascular anatomy, this is the surface of the brain looking from the bottom up. Okay? You've got your internal cerebral arteries on each side, okay? And then they end up going into the middle cerebral artery and the anterior cerebral artery. Then you've got your two vertebral arteries on each side, and they combine to join the basilar artery. And so as far as strokes are concerned, the vast majority are going to be considered what we say internal carotid artery to middle cerebral artery. You know, these are the two big pipes that are supplying the brain. And so 80% of the strokes will end up occurring in this vascular distribution here. And about 15% will end up right here, and about 3% will end up in the anterior cerebral artery distribution. And as far as the brain location and function, this is where, when you see a patient and you're trying to correlate, where is this stroke? And so the middle cerebral artery supplies this whole area right here, okay? And so as you can see, it'll take out the motor cortex, okay? So the arm and leg, okay, will become weak. The frontal lobe over here, right here, is the frontal eye field. This is what moves your gaze to one side or the other. And so that's why patients with stroke, you'll see them kind of staring off to one side and they can't look to the other side even if you ask them to. This part of the brain right here on the left side is responsible for understanding language. This part right here is responsible for producing language. So that's when patients have a stroke with right-sided weakness, you know that this is a left-sided stroke, and the left side is what's responsible for language, and so they become aphasic. They don't understand what you're telling them. You're speaking gibberish to them because this part's gone, and they're mute because they can't say anything because that part's gone, okay? So as far as, you know, a stroke in the field, the faster that you can communicate to us what's going on, the better we can prepare for these patients. And so I believe that you guys use the CSAT. You guys use CSAT or LAMS or
Cincinnati.
Oh, Cincinnati, okay. So this is a Cincinnati stroke triage assessment tool, okay? So going back to that, you know, if you have a gaze deviation where the eyes are pinned to one side, you know, you give them 2 points, okay? And level of consciousness, you know, you ask them what's the age and month, or ask them to follow two-step commands like close your eyes, open your hands, and close your hands. Okay, if they're unable to do that, you give them 1 point. Then you ask them to raise an arm up, and if it falls right back down, or if it starts to drift, you give them another point. And any 2 points is a positive score, okay, where there's a high likelihood, about an 80% likelihood that this is a actual stroke. So when you are, you know, evaluating these patients on the field, it's great for us to know, you know, how high of a probability is this patient that this is going to be an ischemic stroke. What's their last known well, because that kind of plays into the equation as far as what medications we can give them. What is their medication list? Are they on any blood thinners, recent surgery, any trauma, and then also when can we expect you? Okay? And we can then kind of get all the team ready so that we can take care of these patients as quickly as possible.
And Dr. Yoon, so the CSAT has been worked into their protocols now as of this last year, as a rollout to help look for LVO.
Okay, great. So just to go over some examples, I took care of a 58-year-old male with no past medical history, not any blood thinners, no recent surgery. He was actually at work, and he had sudden onset right-sided hemiplegia. The right side completely became weak, couldn't stand, fell over, couldn't move his arm, was aphasic, couldn't talk, couldn't understand what you're saying. His gaze was deviated, and his onset of symptoms was immediate. It was witnessed, and so they called the paramedics immediately. Based on all of these combined together, the CSAT is a 4, so very, very high likelihood that this is an ischemic stroke. And so we got a stroke alert notification in the field, and we started mobilizing things as quickly as possible. First step, when they get to the ER, is to get them to the CT scanner. So is this an ischemic stroke or is this a hemorrhagic stroke? And the pathways will diverge based on the CT scan. The CT scan is looking for a hemorrhage. Is there any bright spots in the brain on a CT scan that's consistent with hemorrhage? And also, you're looking for a dense MCA sign. Okay, that right there is that middle cerebral artery, and that part being bright means that there's thick clot in that artery. Okay, so even without a CTA, we kind of have a clue this is where the clot is. And then we're also looking for areas of infarction. Sometimes if the patients get to us 4, 5, 6 hours out, sometimes it's a wake-up stroke. A CT scan can show us, are there parts of the brain that are irreversibly damaged? Because if the brain is gone, there's, restoring blood flow isn't necessarily going to bring that tissue back. It's gone forever. So we're looking for areas of cerebral edema from dead tissue. We have something called an aspect score. And so if in a perfectly good-looking brain like this, the aspect score is 10, and it goes lower from there. So there's no hemorrhage. There's a dense MCA sign there. There's no areas of complete infarction. Okay? So the patient is a TPA candidate, and TPA is basically a clot buster given through the IV, and the time of onset is less than 3 hours. So we say go for it. So how effective is TPA? So a lot of our studies, a lot of our knowledge comes from the NINDS trial, where they had 624 patients with ischemic stroke within 3 hours. They were given IV TPA, and this is the result versus placebo. So if you look at improvement at 24 hours, TPA is 47% versus placebo of 39%, and favorable MRS at 3 months. Modified ranking scale is basically what is your level of disability. So if you're able to live independently, care for yourself, bathe yourself, feed yourself, that's an MRS of 1, 0, or 1. If you need some assistance, it's about a 2. But if you are at a nursing home, you need constant care from others, people need to bathe you, that's not considered a favorable MRS. So we typically cut the MRS scale around 2, okay? Basically, are you independent or not? Are you dependent on others to live or not? And so looking at favorable MRS, patients that had TPA had 42% of them had favorable MRS at 3 months versus 27. So it definitely works, but it comes at a cost, okay? Intracerebral hemorrhage, because this is a clot buster, it's injured blood. The rate of intracerebral hemorrhage is 6.4% versus 0.6%. Okay, so 10 times higher bleeding risk with TPA, and that goes higher the longer it's been since your stroke. So the rate of IV TPA recanalization, if you look at the MCA, right? If you give TPA within 3 hours, you're looking at around 30% chance that the TPA will work and dissolve the clot. So it's great, it works well. But the only downside is TPA is only given to about 3 to 5% of patients with ischemic stroke. Why is that? Because, well, sometimes we don't know when they went down. We have an indication saying we can only give them 2 to 3 hours, sometimes 4.5 hours from last night low. Well, if it's a wake-up stroke or someone brings him in, he can't talk, we don't know when he had a stroke, we can't give it to them. If they're on any blood thinners, if they have recent surgery or recent trauma, any of those things make them ineligible for TPA because that will continue to increase their bleeding risk. Okay? And so TPA for me is kind of like this Drano. If it's a soft clot, put some Drano in it. Maybe it'll work, maybe not. In the meantime, call the plumber. Right? So the plumber, like me, is thrombectomy devices, okay? And, the first thrombectomy or embolectomy devices were approved in 2004, and they looked like dangerous little spears, okay? And they didn't work so well, and then the technology continued to improve, and so patient outcomes started to improve. And for instance, these are the modern stent retrievers that we use, and it basically goes in and captures the clot so that it can then be aspirated into the aspiration catheter, okay? And so for me, these kind of devices are kind of equivalent to the rotor. So what is the treatment effect of thrombectomy, right? So we go for the number needed to treat. So how many patients do you need to treat to reduce disability in one person, okay? And the number needed to treat based on all these studies here is 2.6. So if you treat 2.6 patients, you'll reduce disability in one patient. And that might sound like not much, like you really have to do, success rate is only 1 in 3. Like, why are we even doing this? It's probably pretty expensive. The number needed to treat for IVTPA is 8, okay? And then, if someone's having a heart attack, you send them to the cath lab for a PCI or a percutaneous coronary intervention, right? So, the number needed to treat for PCI, for a heart attack or a PCI is 45, okay? And so, you think of, if you're having a heart attack, go to the hospital, you're going to go to the cath lab, they're going to, stent you or whatnot. And this is based on the number needed to treat at 45. 2.6 is the number needed to treat for disability in the brain, okay? So, no question, based on these studies, it has quickly become the standard of care. So, going back to our patient, we get a CT angiogram, and sure enough, there's a clot there. So a CT angiogram is basically a contrast bolus into the IV, and we're imaging the brain. And basically highlights all the vasculature in the brain. And you can see this is the internal cerebral artery, internal carotid artery, going into the middle cerebral artery. And right here is a cutoff. On this side is normal, as you can see. And so this is looking at it from the front face projection. This is from the top. And then here you can see that some of the vessels here are not filling as well. At Intermountain, we use Rapid, and at St. Mark's, we use VizAI, and it's a great software tool because it tells us, as soon as the patient gets the scan, it just sends it straight to our smartphone. Okay, so I might be in the shower, and the smartphone just gives a ding saying suspected stroke. I'll take a look, and I'll be able to tell in 5-10 seconds, is this actual stroke or not? Okay, and is this something where I need to call the team in, and do we need to go? So it's a great tool, and it really definitely helps us expedite patient care, so that I'm not waiting for the computer to boot up and logging in remotely and pulling up impacts or, and so it helps a lot. So in that particular patient, his time of onset was less than 3 hours, got TPA, but we're not just going to sit there and wait for TPA to work. We're going to take him to the cath lab or the IR suite and take the clot out. And this is what we do. We basically access the femoral artery at the groin, and we take the catheter all the way up and into the brain. Okay, and we take that catheter up right against the surface of the clot. And here is the first angiogram, and this is the catheter up here, right in the base of the neck. Okay, and I'm injecting contrast, and it's filling up, and you can see that cutoff right there. It's not filling. This is when I then deploy a device. I don't know if you can see that device there, okay? And that's the stent that's being deployed across the face of the clot, okay? And I deploy that, and then I pull that stent out along with this aspiration catheter right there. And this is the clot that comes out, okay? And then I shoot the next angiogram, and it's filling nicely there. So I've restored blood flow, I've reopened the blocked blood vessel. We get a brain MRI a few days later. This is to look for any stroke, and the brain MRI is completely clean. So this patient got to us very quickly. There was no delay in any part of his care, and so his brain is completely unscathed. metric for that particular case, his last known well was 1800. Paramedics had called, and they called it in right away, 1836. So we activated our code stroke 4 minutes before they actually arrived to the ER. So we're ready to receive the patient, took the patient directly to CT, got a head CT at 1850. CTA was given at 2 minutes later based on the negative CT scan. The neurologist was there, triaging everything. The CTA was done at 1900. It showed that M1 occlusion. The neurologist then called me 2 minutes later, said, hey, I've got a patient here in the CT scanner. I gave him CTA. He's got a blockage in the middle cerebral artery. I look at my phone. I say, yep, you're right. Let's go for it. So then I call the team in. We get to pick up the patient. We get the patient in, prep. We have groin puncture at 1948, and then we have recanalization at 2000 hours. So basically, from last known well to recanalization, that's 2 hours. Okay? And so that's a pretty good outcome for that patient. And it's not a whole lot of work on my end. You know, it took me about 12 minutes to get groin puncture and pull the clot out. So it's very gratifying. Not a whole lot of work, very quick, and you've basically taken someone who was going to be bedbound, you know, in a nursing home, potentially even die because this patient was relatively young from the stroke, and he was discharged without any disability at all, walked out of the hospital 2 days later. But this is a product of what we call sequential versus parallel processing. You know, if we had to wait for the patient to get to the ER, then the ER doc then evaluates him and then says, yeah, we should probably get a CAT scan and CT, CTA, and then calls the neurologist. The neurologist comes over, says, yeah, I guess we should probably, this probably looks like a stroke, and then calls me, and then I have to pull up the computer and look at the scan and say, yeah, it looks like a stroke, let's go for it. Then I call the team in, and then they have to come in and set up the angio suite and then transfer and groin puncture. In parallel processing, a lot of this stuff is being done at the same time, you know, to just cut back on how much time, cut back and get the patient to the angio suite and open up the blood vessel as quickly as possible. So here's another case. This is a 28-year-old female who presented with acute onset left-sided facial droop and left-sided weakness. She's otherwise healthy, has no significant past medical history. She was brought by EMS to Dixie Regional down in southern Utah as a code stroke. She then went for a CT scan, and this time, it's not an ischemic stroke, it's hemorrhagic stroke, right? And as you can see, the blood is in the brain, okay? And it's causing a bit of shift, some mass effect. And then the patient gets a CTA, and I don't know if you can make that out, but there's some abnormal blood vessels there, okay? So there's a classic example of a hemorrhagic stroke. You've got a neurologic deficit from brain injury caused by some sort of vascular problem. So what are some of the causes of intracerebral hemorrhage? So you've got just plain old hypertension, coagulopathy, amyloid angiopathy, it's a blood vessel disorder in elderly, aneurysm, vascular malformation, tumors, trauma. One thing to keep in mind is an underlying structural lesion, like a vascular problem, okay, is more likely in younger patients. So about 50% if they're less than 55 years of age, but less than 5% if they're age 60 or greater, because a lot of these elderly patients will have hypertension, coagulopathy, amyloid angiopathy, okay, but the younger patients will have the aneurysm and vascular malformation, okay? And that lady was 28 years old, right? So immediately we're thinking this is very unusual for a young person to have this kind of hemorrhage. We need to do a comprehensive workup. Plus, the CTA does kind of point to something there. So as far as distribution of pathology, if you have a positive CTA, a lot of these are going to be from arteriovenous malformation. 18 or 19% are from aneurysms. Sometimes they have a sinus thrombosis or blood clot in the venous system of the brain, or vasculitis. Sometimes it can be drug-related vasculitis or dural arteriovenous fistula. We won't go over all of those today. If they have a negative CTA, meaning there's no structural vascular lesion, hypertension, coagulopathy, amyloid angiopathy, or tumor. So in that patient, it shows a right basal ganglia intracerebral hemorrhage. It's a hemorrhagic stroke, so obviously you're not going to give TPA in the blood. The TPA doesn't show a large vessel occlusion, but it does reveal an underlying vascular malformation. So this patient was transferred to Comprehensive Stroke Center, which was Intermountain Medical Center where I was working. And so I took her to the angio suite and shot this angiogram. And so this is the internal carotid artery and going to the middle cerebral artery and anterior cerebral artery. Our stroke patient would have had a cutoff right there, but as you can see, there's all these blood vessels, abnormal-looking blood vessels that are coursing up and supplying this tangle of blood vessels here. This is the arteriovenous malformation. And in this tangle of blood vessels, if you look at a close-up, right there, you can see a small aneurysm there. Okay? And that was the rupture point. Okay? That's what bled. Not the AVM itself, but this aneurysm. So what are arteriovenous malformations? So it's an abnormal tangle of blood vessels that connect arteries to veins without a capillary system. So this is what a normal system looks like. You've got the artery, you've got an artery branching into an arteriole, smaller and smaller and smaller. Then you have the capillary system where, oxygen and nutrient exchange takes place to the individual cells. Then you've got the venules and the veins, and then the large veins. And in our AVM, it's basically just a disorganized tangle of blood vessels where there's no capillary system, there's no normal brain tissue in this area, and blood is just freely flowing from the arterial side to the venous side. The incidence is actually higher than you think. It's about 1 in 700. So if you know 700 people, one of them has an AVM. It's thought to be congenital, and the rupture risk is about 2 to 4% a year. And they're commonly associated with intranidal or flow-related aneurysms. And if that is the site of hemorrhage, it's considered to be significantly higher risk of rehemorrhage. So what are AVM-associated aneurysms? So sometimes we just find an AVM and we'll do vascular imaging and we'll see an aneurysm on the other side. And that's just like an incidental, unrelated aneurysm. Has no, effect on rupture risk of that AVM. Or sometimes what happens is because this AVM is drawing so much blood, you have so much more flow going through this artery that you form an aneurysm along the way, okay, from increased turbulent flow. And the way I sometimes explain it to patients is when you have an AVM, you're drawing a lot more current through a small gauge wire, and that wire is going to have some damage to it, okay? And that's the same principle here. And then you've got a distal flow-related aneurysm where right in the smaller arteries that are flowing into this AVM, you've got an aneurysm forming. And then you've got an intranidal aneurysm, where this is the AVM nidus. And so because you have the aneurysm inside the nidus, we call it intranidal aneurysm. And so this right here would be considered a distal flow-related aneurysm. And that definitely needed to be treated. And so I talked to the patient and said, we really ought to get this treated so that we can reduce the risk of you bleeding again. And typically when you bleed again, that second hit is much more devastating than the first. And so what I then did was embolize this branch that was feeding this aneurysm. Okay, so that aneurysm is gone, no longer filling. And this part of the AVM is no longer filling. You see right here, all these branches were filling this part of the AVM, and that part's gone. Okay. The problem with this AVM is that there's branches coming from all over. You've got distal middle cerebral artery branches that are feeding it, and you've got distal anterior cerebral artery branches that are feeding it, and probably even smaller vessels that we can't see on this angiogram feeding this AVM. So I knew beforehand that completely curing her by injecting glue into all these tiny little vessels would not be possible. So I just took out the branch that was most dangerous for her. Okay? So she tolerated that well, and since the rupture site was considered secured, it significantly decreased the risk of re-rupture. So I would say if we just left that aneurysm there, the risk of her re-rupturing in the next year would be about 20%, But now we've decreased that to about 6% this year and then down to 2% every year after that, okay? So significantly decreased the risk of re-rupture, and so I consider that semi-secure, okay? And so then I talked to her about residual AVM treatment options such as surgery, stage further endovascular embolization, and radiosurgery. And they decided to go with radiosurgery, which I thought was an excellent choice. So surgery would be basically making an incision in the skull and opening up the skull, going through the brain, and basically coring out that part of the brain that contains the AVM and, manually pulling it out, okay? The problem with that, or the pros of that, is that you have an immediate resection. You're completely cured, the AVM is gone, you're not going to bleed anymore, okay? You don't have to worry about it, move on. But the problem with her is that it's in the basal ganglia, it's very deep in the brain, okay? And in order to get to that AVM, I'd have to go through about 4 or 5 centimeters of normal brain to get to the AVM, and I didn't feel like at her age that was necessary, okay, or something that she should have, because all that brain tissue that I'll have to go through is going to get injured, okay? And she already suffered one injury. I didn't want to add insult to injury, so significant perioperative risk of neurologic deficit afterwards because of the deep-seated lesion. And then as far as a stage further endovascular embolization, the pros is that it's minimally invasive. There's no surgery and not tearing up your brain. But for her, because there were so many different arteries that were feeding the AVM, and because it's a difficult vascular access with multiple small feeding arteries, I really didn't think I would be able to cure the AVM through that approach. And so the third option is radiosurgery, and the pros, again, is minimally invasive, but the cons is that it's a delayed response. So she'll get radiated, and it takes about 3 years for that AVM to slowly shrivel and go away, okay? So she was okay with, I'm okay with taking that 6% to 2%, risk of rupturing in the next 3 years before this AVM is completely gone. I'm okay with that. Just don't cut into my brain, At least we've kind of decreased the risk of me re-rupturing. Let's just move in that direction. So that's what we decided to do. She ultimately got discharged into rehab and then got discharged home. I saw her in clinic a couple weeks ago, and she has very, very slight left-hand weakness. You probably wouldn't be able to tell unless you knew to look for it, but otherwise it was back to normal function. She was walking, she was moving around, she was shopping, she was actually driving. I told her probably wait for a couple months before she's driving again. But then we have now scheduled her for radiosurgery for that residual AVM. And we got a CAT scan, and you can see all that blood has basically resolved, okay? It's gone kind of dissipated. And that bright spot, that's the areas of the glue that was injected into the artery. Okay. So here's another case. This is a 32-year-old male who presented with acute onset aphasia, or inability to speak or understand language, right-sided vision loss, and right-sided weakness, classic stroke, right? But was found to have a left occipital hemorrhage, like that, okay? And was transferred to IMC, was actually in our ICU for a couple weeks. Unfortunately, did not have an adequate vascular workup, and was discharged inpatient rehab. And then I saw him as a post-op hemorrhage patient, referral. Will you please see him? He had a brain bleed. We should probably figure out why it bled. And so I was looking through his notes, and I saw this bleed, and I saw his age, and I said, well, the likelihood of you having an underlying structural lesion, right, is more than 50%. And so we need to do a complete vascular workup. By the time I saw him, he had some residual vision difficulty, some mild word-finding difficulty, but no residual weakness. And so I recommended a diagnostic angiogram. Okay? And here's the angiogram. Okay? And as you can see, there's an AVM hiding in that blood. Okay? And it would have been otherwise missed if we didn't do that study. And these are branches of the middle cerebral artery that are going all the way back and feeding this AVM in the left parietal lobe. And so the diagnosis here is an AVM. Fortunately for him, he didn't have an aneurysm associated with it. So the rupture risk of this AVM is 6% during this first year, and then 2 to 3% a year after that, every year after that. But he's young, and if you do the math, at 3% a year, let's say he's got 60 years to live, 3% times 60, that's almost a guarantee that this AVM will rupture during his lifetime. Now, if you're 80 years old and we found this, I'd probably say, okay, you're probably going to die from something else. But if you're 30 and you have this, probably should be treated one way or the other. So the treatment approach we took was to do a preoperative endovascular embolization and then a craniotomy for resection of the tumor. And the rationale for this is that if you look at this AVM, it's very superficial. It's right on the surface of the brain. Okay? So it's very easy to get to. And he already had a prior hemorrhage. So the surrounding area of this brain, I don't know if you can tell, but a whole area surrounding this AVM, there's not a lot of blood supply there. This is all actually just blood clot that has kind of created this pocket delivering the AVM to me. So at least I know that if I'm scooping out this AVM, the area of brain around it is all just injured brain tissue from this previous hemorrhage. So very low risk of me hurting him or harming him from taking this AVM out. And then the embolization decreases the blood loss during surgery because I've decreased the blood flow to the AVM. And so here's the endovascular embolization. So here's the guide catheter here, and then there's a microcatheter that basically goes all the way out to here. And I've injected this glue, and you can see the cast inside of this part of the AVM. Okay? And then I then access this part of the AVM, okay, to take care of this part. And then the final angiogram, okay, shows that this AVM is not filling quite as well, but there's still tiny little blood vessels that are still supplying it. Okay? But I wasn't going for a home run. I just wanted to decrease the blood flow to the AVM so that I can then take it out during surgery. And so this is what an AVM looks like from the surface. It's basically an abnormal tangle of blood vessels and with this big draining vein. Okay? And I was able to take it all out, and he tolerated it well, and he was able to go home 2 days after surgery. He didn't have any new neurologic deficits, and I saw him in clinic a month after, and he was doing quite well. And with time, that part of the brain kind of heals. So here's one more example. So this is a 66-year-old female who presented to Jordan Valley Hospital with no significant past medical history, sudden onset headaches, nausea, vomiting, and worsening altered mental status. In this case, you can see this bleeding is around the brain, right? It's in the subarachnoid space. It's not in the brain, it's within the folds of the brain, okay? And this is classic for subarachnoid hemorrhage. Okay? And you can see that the ventricles, which is the fluid pockets in the brain, are enlarged. So the patient's already developing what we call hydrocephalus. So we got a CTA, that shows a small anterior communicating artery aneurysm right there. And she was transferred to IMC. So what is subarachnoid hemorrhage? Well, what causes subarachnoid hemorrhage? Well, aneurysms are the most common cause of non-traumatic subarachnoid hemorrhage. The trauma is the most common cause. So if you had some sort of car accident, some bleeding into the subarachnoid space. But as far as non-traumatic, aneurysms is the most common. And it's there's a high variability in incidence worldwide in different countries for some reason. It's anywhere from 2 to 22 per 100,000 patients, people. And 10 to 15% of patients with aneurysmal subarachnoid hemorrhage will die before reaching the hospital. So it's a big deal. And there's a 20% risk of rehemorrhage within the first 2 weeks. So it's dangerous. And it carries a 50% mortality if you do rehemorrhage. So that second hit phenomenon is real here. So how does subarachnoid hemorrhage cause brain injury? Right? It's in the folds of the brain, it's not into the brain, it's not cutting off blood supply. Well, there's multiple different ways, but in the hyperacute setting, right when the aneurysm ruptures, you have this sudden elevated intracranial pressure from arterial bleeding. So the normal intracranial pressure, the pressure inside of your brain, is anywhere from 5 to 15 millimeters of mercury. Okay? But your typical systolic blood pressure is about 120 over 80. Right? If an aneurysm ruptures, blood is rushing out of the artery, and the only thing that's going to stop this bleeding is a tamponading effect. Right? So for that brief moment until that bleeding stops, the pressure inside of your brain is basically 120 over 80. Okay? And that is that blast injury during the first hit. So that's when patients will say, oh, I've got a headache, and they'll just fall over and go unconscious. Okay? Then, in the acute setting, you have this progressive hydrocephalus. So you've got blood now coating the surface of the brain, in the folds of the brain. When that happens, it disrupts the normal circulation of the cerebrospinal fluid inside of the brain, and the cerebrospinal fluid ends up getting trapped inside of the ventricles. The ventricles start to plump up. It starts to collect more and more fluid. The choroid plexus, which is where the cerebrospinal fluid is generated or produced, they're not smart enough to say, our ICPs are too high, we're going to stop producing fluid. It's just going to keep pumping more and more fluid. And eventually your ICP will go higher and higher and higher to the point where your brain no longer can get blood because of so much pressure. So elevated intracranial pressure greater than 15. And so it's critical to relieve cerebrospinal fluid quickly to prevent herniation and death in these patients. And unfortunately, I've seen too many patients where, they have subarachnoid hemorrhage, and they're in a small town. They get, EMS takes them to the nearest hospital. They do a CAT scan. The patient has subarachnoid hemorrhage with hydrocephalus. They're building up fluid. They're frantically trying to call the nearest comprehensive stroke center. Can you please take care of this? We need a neurosurgeon. We need someone to take care of this aneurysm, right? And they ended up getting life flighted. They have bad weather. They end up taking an ambulance by ground, and then it's 6-7 hours, and the patient arrives dead. And I've seen too many of those cases, unfortunately. And so it's very important to take the patient to the correct hospital. But unfortunately, in these rural areas, there just really isn't any, and a lot of patients suffer from that. And in the delayed phase, we have something called vasospasm. Okay, so let's say you survive the aneurysm rupture, you have relief of your cerebrospinal fluid from a procedure done. Your aneurysm is now secured. You're now just kind of coasting in the ICU. All that blood within the folds of the brain, which is where the blood vessels travel, is extremely irritating to the blood vessels, and they go into what's called vasospasm. The blood vessels start to spasm, and it can be deadly. Basically, spasms so badly that it causes an ischemic stroke to those territories of the brain. And so they need close ICU monitoring. We keep them in the ICU for 2 weeks, and we have to provide medical and endovascular therapies to prevent ischemic stroke from vasospasm, even though they've made it over that initial hump. So what causes the aneurysms? We don't really know. About 20 to 25% are familial, meaning there's definitely a genetic component to it. There's the lactic effect, so if you have a collagen vascular disease or any soft tissue disease, inflammation, atherosclerosis, hypertension, hemodynamic effects, smoking, also being a woman. Women are 1.4 times more likely for some reason. They typically happen in the anterior communicating artery in that one patient, sometimes in the posterior communicating artery, middle cerebral artery, basilar artery. And so those are the most common areas where you'll form an aneurysm. And as you can see, these are typically at these bifurcation sites, meaning the blood is traveling one way, and it has to then bifurcate or split into two, and these aneurysms then form. Same thing here, same thing here, same thing here. It's almost like the red blood cells are traveling, and they end up being asleep at the wheel and hit the center divider. They create these aneurysms. So what is the typical presentation of rupture? Thunderclap headache is the classic definition. So they're just minding their own business. Sometimes they might be exercising. Maybe they're having an argument, and they'll have the worst headache of their life. And then they'll lose consciousness. Okay? Sometimes it'll just be transient because that blast effect takes them down, the bleeding stops, the pressure kind of normalizes, and they'll wake up. And then they'll say, oh, that's very strange, but I'm still having really bad headache, nausea, vomiting, very stiff neck, photophobia, bright lights are bothersome to them. And then they'll start to become somnolent. They get a little bit drowsy, they're starting to doze off, and then they become obtunded. And this is the evidence of hydrocephalus. And so how do we treat hydrocephalus? We place an external ventriculostomy drain. And this is an emergency procedure that I'll oftentimes do right in the ER. I've done it in the CT scanner once. Sometimes we'll do it in the OR. Sometimes we'll do it in IR. But it's an emergency procedure to relieve all that fluid buildup in the brain so that we can normalize the intracranial pressure. And it's a freehand technique using known anatomic landmarks. Okay? And basically make a cut around there. And small stab incision, a handheld drill, okay? Twist drill, make a cut in the dura, and then pass the tube through the brain into that fluid pocket there. Okay? And then that excess fluid that's being generated in the ventricle is able to be siphoned off through that drain and relieve pressure. So this patient with the ruptured anterior communicating artery aneurysm, I took her to IR, and this is the angiogram. You can see this aneurysm that's formed off the anterior communicating artery. Okay? And then I was able to coil that aneurysm. You can see that it's no longer filling. Coils are basically small platinum slinkies, as you will. Just kind of like helical configuration of small platinum wire that is pushed into the sac of the aneurysm, and it basically causes blood to thrombose. It causes the blood to thrombose inside of the aneurysm and causes it to clot off, as you can see here. And so I placed an EVD also, and that EVD, as you can see, is resting inside of that fluid pocket. Okay. And this is the artifact or metallic artifact from the coil. So she recovered in the ICU. Unfortunately, her hydrocephalus, or the fluid buildup, was persistent even after 10 days after we tried to clamp the external ventriculostomy drain. So then I had to put in a shunt, and she was discharged to inpatient rehab, and she's now at home, almost fully recovered. So, yeah, back to her normal self. So I know it kind of went over a lot of different topics, kind of disorganized, and I apologize for that. But in conclusion, stroke is the leading cause of serious long-term disability and third leading cause of death in the United States. 87% of stroke is ischemic, 13% is hemorrhagic. Timely transport to the correct hospital is critical in preventing death and disability. And improvements in communication and technology have significantly improved patient outcomes. And this hospital, St. Mark's Hospital, is expanding the neurosurgical and neuroendovascular service line to be able to take care of all causes of stroke, both ischemic and hemorrhagic. And in fact, we've already taken care of a ruptured AVM, ruptured aneurysm, taken care of several unruptured aneurysms, and I just treated an aneurysm this morning. We're well on our way. Any questions?
That last patient, did you do an abdominal shunt with that, or where did you run the shunt?
Yeah, so it's a ventricular peritoneal shunt. So basically the catheter goes underneath the skin into the peritoneum. Yeah.
Do we have any questions from our people online?
Yeah, hey, Dr. Yoon, this is Dr. Grants.
Oh, great. So Dr. Grants is going to just take a couple minutes while we've got him.
Well, Dr. Yoon and Holly, thanks for doing this. It's a great chance to showcase your definite skills, Dr. Yoon, and thank you, Holly, for getting all the fire stations and, of course, their time to join us. Once again, as Dr. Yoon's noting, that we're primary stroke plus, meaning that we've got all the thrombectomy capabilities, and with Dr. Yoon's arrival, we're definitely growing into this area. St. Mark's with the MountainStar has a large number of referring facilities, so once we're getting the core team on board, once again, Dr. Yoon, some of the neurosurgeons that back him up, and of course our own capabilities, we're really excited to be moving toward Comprehensive Stroke Center. This is a push that's coming down from all directions, from our community wanting us to be involved with this, and then also the corporate really excited about growing this in this direction. So, for a while it's just been University of Utah and IMC in this game, and I think with Dr. Yoon and us growing our capabilities, intensive care unit and nursing staff, we're really excited to be getting into this space. So once again, as time moves forward, I really expect to, be a really, partner with you guys just as much as we do for ischemic stroke for these hemorrhagic and kind of more intense aneurysmal hemorrhage cases. So once again, really appreciate everyone's attention and ability to join, and really excited to work right alongside with Dr. Yoon in taking these critical patients.
Awesome, thank you. Do we have any other questions? Okay, big huge thank you to Dr. Yoon for presenting for us today. You did a great job. Do you have a question? We have one more question.
I do have one question. So what would you say, what's the time frame difference for thrombectomy? Yeah. IMC versus coming here right now. So team assembly, what would be the difference for that to happen time-wise?
So as far as ischemic strokes, I think, St. Mark's and IMC are basically on par. Okay.
So no time difference. So if we brought a patient IMC versus bringing them to St. Mark's, there's no time difference for that to take place.
Yeah.
Okay.
So, yeah, we basically have the same time metrics, same same systems in place.
Okay.
To try to get the patients, the care they need as quickly as possible. I think right now what we are lacking is the hemorrhagic side of things. We're still building so that we can accept these patients and provide them all the care that they need.
Mm-hmm.
And we're anticipating that we'll have all of those systems in place within a few months. But as far as ischemic stroke, St. Mark's has been doing mechanical thrombectomies for several years already, and because of their results and their timeliness in thrombectomies, that's how they received the primary plus stroke certification, which is just one step below the comprehensive. Basically, the only difference between comprehensive and primary plus is being able to care for these hemorrhagic patients.
Okay. Thank you.
I think one thing too, to just kind of reiterate from the St. Mark's perspective, is that when you guys initiate from the field, so you have a positive Cincinnati and a positive or positive CSAT, as soon as you call us in and say that, hey, I've got a stroke coming, we initiate that team based off of what you guys say, and that's when we meet you in that ambulance bay. And the whole purpose of meeting you in the ambulance bay versus having you bring the patient to a bed in the ER is it saves time, right? Because as soon as we get a patient into the ER bed, we kind of want to put them on monitors and that kind of stuff, when we don't need to do that with these stroke patients. The most important thing is the CT scanner. And so when we meet you right there at the scale, we weigh them, and you guys go right with us to CT scan.
Yeah.
And you're welcome to stay and watch the CT scan, and if that patient goes to IR to get a thrombectomy, you're welcome to follow that patient there also.
And you've been very thorough when we make that call in as far as meeting us and making that happen, so that's good.
And then any stroke patient that receives TPA or has a thrombectomy, and as we expand into our hemorrhagic stroke that has any kind of procedure that's done, those will get reviewed back to the crew at the station.
Okay.
I'll bring that out to you, and we'll sit down and we'll review the whole case.
Go ahead. Now, for hemorrhagic, just from the time of onset, is there not time limit, but how long does it take for the patient to be less severe differences? Or does it depend on where it ruptures?
Yeah, it really depends. As you saw from the intraparenchymal hemorrhages, if they're in a certain location where the patient will tolerate, recover from it, for instance, that young lady who got the embolization and is going to get radiosurgery, to be honest with you, if she would have probably recovered fine if I had done nothing, she would just be at risk of rehemorrhage. Her recovery was really all just on her own. As far as the aneurysm patients, it's the same kind of deal where sometimes these aneurysms will seal off by themselves by the time they get to us. But what we're really doing is making sure that the aneurysm doesn't rupture again and securing them for the future. And also if they're developing hydrocephalus, and we're relieving the intracranial pressure. So it's really, I would say that for patients with hemorrhages, it's really the emerging part of it is relieving pressure in the brain, either if it's a massive hemorrhage where we need to decompress the brain or evacuate the hemorrhage, I could have showed more cases where I've had to do that, where I have to evacuate the hematoma to relieve the mass and relieve pressure. Or in these aneurysm patients where they are developing hydrocephalus from excess cerebrospinal fluid buildup, and they need that simple procedure, done to save their life. So, in certain patients, an intracerebral hemorrhage with a large amount of mass effect, it could be a couple of hours before they expire. And with hydrocephalus, it could be a few hours.
One more question. So in the field, it's in the protocol, 2 large lines established before we bring them in. Is that a line that's going to be utilized by you for doing that, or are you going to have a different access? So I'm wondering why the 2 large lines in the field versus what you might be doing.
I think we just prefer to have those 2 large lines, so we've got lines capable to give the medication. So especially we have to get their blood pressure down, and we have a line for TPA. So the more lines we have, basically just the quicker we can take care of that patient.
I'm not just wondering that for TPA, is that an access that you would use here? When we start that in the field, I know sometimes that was an issue, so I just wanted to clarify.
Yeah, well, and when you're in the field, we don't want you to delay care at all, right? So if you can get that as you're cruising in, absolutely. And yes, we do use your line.
Okay.
Any other questions? Any other questions online? All right, great dialogue with everybody. Huge thank you to Dr. Yoon.
Thank you very much.
He did a great job. And then, if for those of you who are joining us on the WebEx, if you can make sure you've texted your name and station to my cell phone, 801-755-3317. That way we have you on our attendance roll, or you can actually chat it here in the WebEx itself. Thank you. Have a great day. Stay safe, stay healthy, and go out and conquer.
Bye. Well, thank you very much for doing that.
Yeah, thank you.
Fantastic. Thank you, Holly.
Yeah, thank you, guys.
Thanks, Holly.
Thanks for being here.
Thanks for coming.
Yeah, thank you.
I'm just trying to show all this down. Run through this a little bit. Because people are starting to send things in.